So my name is Professor Tim Briggs, consultant orthopaedic surgeon. I'm the National Director of Clinical Improvement Elective Recovery, and I also chair the GIRFT programme. So the GIRFT programme was started by myself at the Royal National Orthopaedic Hospital in 2010, with our first visit to a trust in 2012. What it relied on was data. We got 12 sets of data together in orthopaedics, my specialty, and then we sent that to every trust, and then we went to visit to discuss the data, what they were doing well, how they could improve. From there, it's now got across 42 specialties, and so before COVID, we now knew, and we now know what good looks like in those specialties. As we've come out of COVID, we've been asked to drive elective recovery, following a pilot we did in London, the HVLC programme, about transforming their elective services. And now we are transforming care in outpatients on the non-admitted pathway, the admitted pathway through right procedure, right place, day case rates and theatre productivity. But also we've been instrumental in delivering and developing the hubs, surgical hubs, which now number 116 and will go to 133 in total by the middle of 2026. Currently, if you look at the waiting list, it's been coming down every month for the last 6 months. If you look at the patients on the wait list, 80% is in outpatients. So we know we've got now much better theatre productivity, much better day case rates, the best they've ever been in the NHS. We've got the surgical hubs to do the work when patients are admitted, but we've got to get on top of our outpatients. So for me, the outpatient programme started with Further Faster, developing the 16 playbooks to drive really good standardised practice, building on PIFU, DNA, reducing DNAs, making sure we're discharging our patients, not following up those patients that could be discharged. And now we're looking at the clinical templates, standardise those per specialty. That will make a significant productivity gain for our NHS, which will allow us to see more patients and get our waiting times down. We're all in this together. We've all got to stand up to the plate because patients want a good service and they're expecting of us that from us. And so we've got to work together with clinicians and management teams across trusts and throughout systems, working together to identify the best practice, implement the service that's going to work for everybody, and therefore provide the service that our patients are expecting. I think outpatients, the work we're doing, I think we can transform that. On the electives, the surgical hubs are going to be, I think, a game changer in terms of driving elective recovery for patients to do procedures. We're going to have a total of 144 with the new round of funding coming through. Currently, the 107 hubs that are reporting are doing just shy of 200,000 cases a month. So they're going to have a huge impact, I think, on maintaining elective care, which will help with the urgent care, which again is something we're going to have to get right. We can't have patients waiting a long time in casualty. We can't have patients continuing corridor care. But I think working together on both UEC and elective, because the two come together, we can make a big improvement. And we must also do the same for children. The CYP programme and recovery is as critically important as it is for adults.